Welcome to the unit on group and family counseling. In this unit, we will discuss family counseling theories, practices, and interventions, group counseling theories, practices, and interventions, psychosocial and cultural impact of disability on the family and the individual, attitudinal barriers for individuals with disabilities, and individual and family adjustment to disability. Group therapy, where two or more individuals constitute a group, is complex and dynamic. The group therapy process can be broken down into 11 therapeutic factors. Therapeutic factors are the beneficial aspects of group process, which are the result of the facilitator, the group as a whole, and individual members' interaction around therapeutic goals. These factors represent the diversity of human experience as they manifest within group settings, driving group complexity and dynamism. Installation of hope. Hope is a motivator, and faith in a treatment modality builds self-efficacy, leading to therapy maintenance and allowance of the other factors to occur. Universality. Members enter a group feeling isolated and alone in their presenting conditions. Although they present with unique circumstances and individuality, they learn they are not alone, and this brings some level of comfort and relief for them. Imparting information. Group information, for example, psychoeducation, process information, throughout the process is provided directly from the therapist to members and by members to other members. Altruism. Members enter the group process feeling as though they are a burden and have nothing to offer others. They learn what they share is valuable and important to others. They do this on an intrinsic level, building a sense of self-worth. The corrective recapitulation of the primary family group. Members typically, but not always, enter group therapy having come from less than satisfying experiences with their family of origin. As members situate themselves within the group and become comfortable with the group, they begin to manifest interactional styles reminiscent of how they typically interact with their family of origin. Development of socializing techniques. Members in all groups work to develop basic social soft skills. The skill sets vary across group types. This may include role-playing. Imitative behavior. Members may imitate the group leader or other members in the course of group therapy. This is more common in the early stages. Imitation may be utilized as a therapeutic or, for example, vicarious technique within the group setting also. Interpersonal learning. The application of individual therapeutic processes by the counselor to the group process, which is focused on therapeutic change. Members gain insight into and find meaning in their presenting conditions. Group cohesiveness. The therapeutic influence of cohesiveness in group therapy is analogous to the working alliance in individual therapy. Cohesiveness reflects a sense of belonging and solidarity within groups. Catharsis. Adaptive emotional expressions towards the group leader and/or other group members. Existential factors. Members learn honesty in and recognition of the truisms of life and death, and that they are ultimately responsible for themselves regardless of how close they are with others. The presence of a disabling condition does not necessarily limit the usefulness of group therapy or occurrence of the therapeutic factors. Disability is an important consideration. Group content may need to be modified in favor of group processes in some cases. For more information regarding group therapeutic factors, check the additional resources for this module. According to the American Association for Marriage and Family Therapy, marriage and family therapy is as effective, if not more so, in the treatment of individual mental health conditions and drug abuse. They suggest that marriage and family therapy is brief, an average of 12 sessions versus the average of 13 for individual therapy. Solution-focused, specific with attainable therapeutic goals, and designed with the end in mind. Family therapists believe that the most significant forces in our lives lie outside of the self and in a person's family. Family therapy addresses change within the family as a system, which has an impact on each member. An individual is not the sole focus of the therapy, rather, The person and the nature of their relationship and role within the family system is the focus. Positive outcomes can be long-term because family members tend to reinforce therapeutic goals. Nichols uses the phrase, thinking in lines, thinking in circles, to describe the differences between individual therapy and family therapy. In individual therapy, the counselor only hears one side of the story, and problems are generally credited or blamed on one person. It's quite linear. However, the problems people tend to experience are complex. Family therapy looks for patterns where individuals influence each other. For instance, a parent may experience problems with children as a result of what they unknowingly taught them. Looking at the whole picture can help people understand what they are doing to influence others and what they can change in themselves. The most influential model of family dynamics and cybernetics, which Nichols describes as the study of feedback mechanisms in self-regulating systems. A cybernetic system uses feedback about its functioning to maintain stability. The feedback loop is the basis for the system. Negative feedback indicates how far off the mark a system is straying and the corrections needed to get it back on course. Positive feedback is information that confirms and reinforces the direction a system is taking. Situations that would be particularly suitable for family counseling include issues with family changes, marriage or relationship problems, family feuds, or problems with children. In this section, we will review the classic schools of family therapy, Bowen Family Systems Therapy, Structural Family Therapy, and Cognitive Behavioral Family Therapy. Murray Bowen developed family therapy in 1955 while working with large groups of families who had children with schizophrenia. Although he often worked with individuals or couples, he focused on multi-generational family systems. Bowen saw the primary problem of families as emotional fusion, which is an unhealthy, exaggerated need for others. The goal of development is differentiation, which is staying in contact with others but maintaining individual integrity. According to Bowen, the most important relationship in life is that of parents and child, and the triangle is the most important unit of analysis. Bowen used several techniques in therapy, including the following. Genogram. This is essentially a family diagram that tracks data and key triangles. Neutralizing triangles. This is based on the idea that people develop triangles to develop stability in conflict. The family will try to engage the therapist in a triangle, but it is important for the therapist to stay out of the triangle and let the family work out their problems. Relationship experiments. This involves having people try out different techniques to see what happens to clarify the emotions involved. Coaching. The therapist avoids becoming involved in triangles or taking over, but helps clients figure out their roles in processes by asking questions. The I position. This is the difference between saying you're lazy and I wish you would help more. Making the focus less personal and threatening increases objectivity. Developed by Salvador Minuchin, this theory is one of the most widely used models in the field of family therapy. It's simple, inclusive, and practical. The entire family structure needs to be taken into account, not just the subsystems. For instance, problems between a father and son should also consider the mother and other siblings. There are 7 steps to structural family therapy: joining and accommodating, enactment, structural mapping, highlighting and modifying interactions, boundary making, unbalancing, challenging unproductive assumptions. Gibson and Mitchell in 1990 make clear the distinction between group counseling and therapy. They state that group counseling involves assisting with routine adjustment and developmental experiences in a group setting. Group therapy, on the other hand, is used to assist people with more profound adjustment, emotional, or developmental maladaptations. Examples of group counseling could include providing behavior modification, assisting with the development of interpersonal skills, or addressing concerns with human sexuality, values, and career decision-making. Group therapy is typically different from individual counseling in both the length of therapy required and the intensity of the experience for all involved. Rehabilitation counselors can use group counseling as a complement to one-on-one counseling. One key way in which group counseling can be useful is that it can be a method of sharing information. The advantages of using a group counseling method in addition to one-on-one is that groups make it possible for counselors to use their time more efficiently, and they can observe clients in a situation that requires interpersonal behavior skills. In addition, group members may also serve as role models for other members, and a group can provide a strong sense of support for clients learning to take risks in social situations. Sharing feelings in a group setting can be especially beneficial because clients often think they are the only ones who feel the way they do. According to Corey and Corey in 2010, group psychotherapy is as effective as individual therapy in treating many problems, and is actually the preferred treatment for some problems such as grief, trauma, and adjustment. Because it can be as effective as individual therapy, and it requires less time of the counselor, it seems to be the least expensive treatment. Groups tend to fit well with the managed care philosophy since they are brief and cost-effective. Group counseling occurs across a diversity of applications, clinical foci, settings, and clinical techniques. Corey and Corey in 2010 recommend an integrative model of counseling for groups to utilize the most effective components from a variety of approaches. Gibson and Mitchell in 1990 provide a list of the goals for each type of group counseling theory. Psychoanalytic helps clients re-experience early family relationships and uncover buried feelings to enable a therapeutic emotional experience. Adlerian assists clients in exploring their basic life assumptions, their role, and belonging to the family system, and helps them gain an understanding of how members contribute to the family atmosphere. Clients can gain recognition of their strengths and ability to change, as well as to accept responsibility for their lifestyle and necessary changes. Psychodrama can establish clients to let go of suppressed feelings, assist clients in gaining insight into more effective behaviors, and allow exploration of new ways to solve conflicts. Existential facilitates self-awareness and helps reduce obstacles to growth, assists clients in discovering the freedom of choice and assuming responsibility for their choices. Person-centered creates a safe environment in which clients can explore their feelings and become open to new experiences, encourages living in the present, developing openness, honesty, and spontaneity, and enables interaction in the present while avoiding alienation. Gestalt encourages members to pay attention to their experiences in the moment to enable them to identify and integrate disowned facets of themselves. Transactional analysis assist clients in becoming free of scripts and games within their interactions with others, and challenges members to re-examine decisions and make new decisions based on an increased awareness. Behavioral assists in eliminating maladaptive behaviors and learning new and more effective behaviors. Rational emotive behavior therapy helps group members work through psychological disturbances through identifying the beliefs they hold arising from events leading to the cognitive, emotional, and behavioral consequences leading to dysfunction. The overarching goal is to replace the irrational and self-defeating beliefs with more rational beliefs. Reality assists members in moving toward responsible and realistic behavior by evaluating their behavior and developing a plan for change. Members learn to accept responsibility, which leads to an awareness of the realities of life and the ability to make changes toward gaining effective control of their life. The concepts from cognitive behavioral, experiential, and psychoanalytic individual therapies reviewed earlier also apply in family therapies. In these approaches, knowledge of family dynamics and cognitive principles are applied to treating family systems. The stages that groups move through are usually not linear, predictable, or neat. Following are the typical stages a group goes through, along with a description of what the group leader may need to attend to during each stage. Keep in mind that every group is different. Pre-group stage. The group is planned during this stage. First, the group needs to be defined by answering some basic questions. What type of group is it? Long-term or short-term? Who is the population? What are the goals? Is the facilitator trained to lead this type of group? What structure and techniques will be used? How will difficult situations be handled? During this stage, determine a rationale and objectives for the group. Consider practicalities such as defining membership, meeting times, procedures, and evaluations, and inform and prepare group members for the process. Taking time in this step will pay off later. Initial stage. This stage involves orientation and exploration. Members are concerned primarily with acceptance, approval, commitment to the group orientation structure, and meaning. There is usually some anxiety and uncertainty, which should be expressed. As the members get to know each other, they will develop norms and goals and solidify how they feel about the group. Trust is a major issue during this stage. Transition stage. This can be a challenging stage which occurs before a group begins to interact at a level aligned with their capability. Members tend to be concerned with being in or out and top or bottom. In other words, they ask themselves, do I want to work in this group, and where do I fit in, respectively? The leader needs to help group members determine how to work on the concerns that brought them to the group. The members need to learn how to express themselves verbally and risk saying things that may not feel safe. It's important for the leader to recognize the members' apprehension. Also, leaders need to provide a model for members by dealing with the challenges and conflicts directly and tactfully. Working stage. The transition and working stages are likely to merge. The working stage is the most productive stage where the group focuses on behavioral change. Members tend to be concerned with intimacy and closeness, feeling a near or far orientation to group members. Regarding self-disclosure, safety, and boundaries. Trust and cohesion tends to be high, communication is open, and members feel they can take risks. Conflict is dealt with effectively and directly, and feedback is provided. Confrontation is not judgmental. Members work outside the group and feel supported and hopeful. Individual differences in each member will emerge as some members are more engaged than others. Leaders need to balance between support and confrontation while linking together members' issues. Some groups may never reach a working stage. Final stage. This is where members clarify what they learned and adapt it for use in their everyday lives. Members are concerned with deep engagement in the therapeutic process, which tends to be more effective and meaningful for them. This stage shifts group processes towards resolution, maintenance plans, and providing closure. Members might deal with feelings of separation and should build action plans and strategies for coping with relapse. The term group process encompasses all of the aspects of group development from its formation to termination. It includes all the dynamics of a group, such as how close the group is, the norms that develop, challenges, and the developmental stages through which the group progresses. Group techniques refer to interventions initiated by the group leader to facilitate movement and change within a group. In general, techniques encompass anything the leader does, such as using silence, offering feedback, interpreting each group member's comments, assigning homework, asking the group to determine the group goals, having a member practice a new behavior, helping members summarize what they learned from the session, challenging a member's belief system, and having a person repeat certain words. It is important to be aware of and address the impact of a disability on an individual and their family and how this affects the overall rehabilitation process. Is the consumer dealing with issues that will have an impact on their ability to achieve their vocational goals? Will it impact their quality of life? The impact of the disabling condition can be as great on the family system as it is on the individual with the condition. In general, absent or weak support systems can compound the difficulties an individual may have adjusting to a disability. Strong support systems can help facilitate adjustment to disability for an individual. How significant others such as spouses, children, siblings, and friends respond to someone with a new disability will be a major influence on the rehabilitation and adjustment process. An absent or weak support system will potentially compound adjustment difficulties. while a strong support system will generally assist adjustment. Either way, familial adjustment to an individual's disability has an impact, positive or negative, on their adaptive adjustment to disability, both the individual and each member of the family support system. Acquiring a disabling condition tends to cause diminishment of their and the family's social network. When a family is excluded from the rehabilitation process, challenges to successful rehabilitation can be compounded. Parental response to having a child with a disability has a significant influence on the child's self-perception and adjustment to disability. Since most parents do not expect to have a child with a disability, they often experience grief, confusion, dismay, and anger. Usually these feelings subside, but sometimes they may lead to overprotection or even rejection of the child. Parental response is influenced by beliefs regarding disability, coping skills, stress management skills, child management skills, and support networks. Cultural beliefs influence how society views the individual and family affected by disability. For example, specific cultures may view a child with a disability as a punishment for a parent's sins. Rehabilitation counselors can provide disability-related information but should refrain from challenging cultural belief systems. Rather, the counselor could refer the family to another appropriate community service provider. The counselor can help families realize that overprotectiveness and forced dependency often contribute to social immaturity and impaired decision-making. Although a lot of emphasis is placed on the medical and quantifiable aspects of disability, it's important to remember that disability impacts all areas of life. Adjustment to disability is a very individualized and personal experience. If people are dealing with issues in their personal lives, it can be very difficult for them to concentrate on work. Part of the job of the rehabilitation counselor is to take a holistic view of clients and identify barriers or potential barriers to achieving vocational goals. Vocational rehabilitation counselors' provision of services, including information and referral, is critical to effectively addressing consumer needs and helps ensure consumer empowerment, well-being, and job satisfaction along with positive programmatic outcomes. An attitude is comprised of three components: cognitive, affective, and behavioral. How we think, feel, and act. Where do negative societal attitudes come from? In general, people don't like what they don't understand. They may ask themselves, what caused this, or who is responsible? Can it hurt me? These are typical reactions and shape attitudes towards people affected by disability. Perceived cause. What society perceives to be the cause of a disability has a major influence on how the person with a disability is treated. Perceived responsibility. People who become disabled from external events are typically given more compassion than those seen as responsible for their disability. For example, a war veteran who sustained a disability as a result of fighting for their country is generally viewed more favorably than an individual who receives an injury as a result of driving a vehicle while intoxicated. Compare the attitudes towards obesity, sex offenders, AIDS, and criminals to attitudes toward people with sensory or congenital disabilities. Who do you view more favorably? Perceived threat. Some people with certain disabilities may be viewed as a threat to the personal safety of people without disabilities. Take, for example, myths about the spread of AIDS. In addition, sex offenders, people with mental illness or developmental disabilities, and substance abusers can be viewed as likely to be physical or physically violent. In addition, people with disabilities may be seen as a threat to the economic well-being of the country by draining resources from the larger population. Employers may fear increased workers' compensation rates, loss of productivity, higher absenteeism, and the costs of accommodations. Civil rights legislation seeks to combat negative issues toward people with disabilities. The American with Disabilities Act of 1990 includes people with disabilities as a protected class. Rehabilitation counselors can work to change attitudes by using person-first language, avoid demeaning or segregating labels, and respectfully educating others about disability. The Centers for Disease Control offer guidance regarding speaking with or about people with disabilities. People-first language is used to speak appropriately and respectfully about an individual with a disability. People-first language emphasizes the person first, not the disability. For example, when referring to a person with a disability, refer to the person first by using phrases such as a person who, a person with, or a person who has. Why does one person react differently to the disability experience than another? Adjustment to disability is a highly individualized experience. It is influenced by a variety of factors, including the individual and family attitude toward disability, the type of disability and time of onset, and the individual's immediate and social environments. Disabilities may be congenital, present at birth, adventitious, occurring at any time over a person's life, or developmental, developing over time. The experience of a congenital disability is different than that of an adventitious disability, and that development of the personality and body image incorporates the disability throughout the stages of human development. An individual with a congenital disability has increased time and experience with the disability and may develop more resiliency and flexibility. It is a part of who they are, their self-concept, having no life experience without the disabling condition. Common congenital disabilities seen by VR counselors include Down syndrome, cerebral palsy, and muscular dystrophy. An adventitious disability often occurs without warning and is acquired later in life, late adolescence or adulthood, when an individual's personality, self-esteem, and body image have already developed. An adventitious disability disrupts life roles, plans, and self-concept and typically results in a grief and loss response. An important concept to remember is that adjustment to adventitious disability is not necessarily a function of the severity of the disability. The pre-disability personality of the individual is the most important factor in how they will adjust to their new situation. Individuals who are well adjusted prior to acquiring a disability will likely adjust to an acquired disability much more effectively than those less well-adjusted individuals. In general, how well a person has coped with past adversity in their life is the best predictor of how they will cope with a new problem. Common adventitious disabilities seen by VR counselors include spinal cord injuries and multiple sclerosis. Children with disabilities need normal developmental experiences for transition into adult life. From a psychosocial perspective, children with disabilities need to have their special needs met without being overly protected. Being both overly protected and not having special needs met may result in arrested development or developmental delays. Such delays may be intellectual, educational, or emotional. This plays a critical role in education, transition, community living, and employment. There are many similarities between human rejection to death and dying and the grief and loss response to disability. Elizabeth Kubler-Ross's adjustment model for death and dying can be applied to understanding adjustment to disability. Her model includes the stages of denial, anger, bargaining, depression, and acceptance. Two potentially major differences between adjustment to dying and adjustment to disability are that with disability there is seldom time to prepare emotionally and behaviorally to the change, and disability is often accompanied by social stigma, prejudice, and discrimination. It is generally accepted that the process of psychosocial adaptation to disability involves a series of individually experienced reactions. Adjustment is not a linear process. A person does not spend a specified amount of time in any one stage and then graduate, moving on to the next stage. Individuals and families can slip back and forth between stages, principally spending most of their time in one stage and then another. Effective physical, social, and psychological adjustment to a disabling condition includes developing a realistic plan for moving forward, development of effective coping skills, working through the ongoing changes brought about by the disability, and overall coming to terms with the impact of disability on life. Change can impact every member of a support system. Models of adjustment to change delineate the stages people go through toward adjusting to a given change. There are many models of change adjustment, but these can be broken down into 5 general stages. Typically, these steps represent a linear progression. Initial impact. Shock and anxiety characterize the initial reaction to acquiring a disabling condition and the ensuing panic regarding severity, diagnosis, and trauma. Defense mobilization. Bargaining and denial characterize an individual's expectation for recovery. There is resistance to receiving help from others in service of self-protection in the face of change. Initial realization. Ambivalence and emotional liability characterize the initial acknowledgement of the change. Resentment, mourning, anger, and depression tend to be prevalent. Retaliation. Rebellion and outward aggression characterize a person's response to functional limitations and tend to be directed at other people, objects, and contexts associated with the acquisition of the disabling condition. And reintegration. Acknowledgement and acceptance of the disabling condition characterize the integration of the condition into a person's self-concept. According to Livna and Antonek in 1997, an individual is considered well adapted to their disability when they actively participate in social, vocational, and avocational pursuits, successfully negotiate their physical environment, and maintain an awareness of their remaining strengths, assets, as well as limitations.